Yeah, the fluid will be going retrogradely. So when it goes retrogradely, you can imagine, guys, what is going to happen to the GFR? We are pushing backward. What happens to the GFR? Exactly, it decreases. What happens to the filtration if the GFR decrease? What happens to the filtration fraction? Decrease as well. So you can see why this disease, well, basically kidney stones are serious. They can basically affect your GFR. Okay. Exactly, they increase the hydrostatic pressure, but the question is, do they increase the hydrostatic pressure in the Bowman's capsule, or do they increase it in the capillaries of the glomerulus? No, it's in the Bowman's capsule. Look, the Bowman's capsule is here. The capillaries are there. So now we are pushing upward, yes? This is basically the BCT. So when you don't have movement of the urine downward, it will go upward. In this case, it's going retrogradely. So when that happens, the pressure in the Bowman's capsule is much higher, pushing the fluid back against the capillary. And that decreases the GFR, and that also decreases the filtration fraction. So it can lead to severe complications such as hydronephrosis and pyelonephritis. What is pyelonephritis? Well, basically pyelonephritis is an ascending infection of the upper urinary tract. Also, it can lead to acute kidney injury. Well, if you are pushing against the kidney, look what happens. I'm pushing against it, pushing against it, pushing against it. It will start to become thinner and thinner and thinner until it becomes in a really bad shape. Let me actually show you this. Hydronephrosis. So if you take a look at a hydronephrotic kidney, you can see how the pyramids are becoming more squished and squished and squished. They're becoming more destroyed as this progress, basically. See? So initially you have pyramid, mild, moderate, severe. The pyramid are eaten up. They are destroyed. And keep in mind what is located inside of our pyramid. What do we have inside of our pyramid? So your nephron is located inside of your pyramid. So the pyramid has the cortex of the kidney and has the medulla of the kidney, okay? So it has both portions of the kidney. And here you go. So as you can see, inside of the pyramid, there is the two structures of the kidney. Both the pyramid and the, both the cortex and the medulla. So do you remember, guys, what is considered the watershed area of the kidney? The medulla of the kidney, mostly the straight portion of the proximal convoluted tubule and the ascending portion of the thick lobe of Henle. Okay, so let's take a look here. They write obstructed stone presents with unilateral flank pain, Brudzinski sign we call it. Colicky vein radiating to the groin. So what does it mean, colicky? Colicky vein, it means that the vein comes and goes. It's not persistent. Let me give you an analogy here. Any vein that is due to obstruction in an organ that undergo peristalsis will lead to colicky vein. Let me show you what I mean. If we are speaking about the gallbladder, I think this color is not good for the screen, so let me do black. If we speak about the gallbladder, okay, and inside of one of its duct there is a stone. Each time the gallbladder will contract, you will feel pain. So the gallbladder basically undergo the process of peristalsis. So each time the gallbladder will peristalse, you will feel pain. So what do we call this pain? We call it colicky vein. Okay? Okay, so this is one example. Another form of the analogy. You have your appendix. And if we say that a fecalith has occluded the appendix, each time the appendix have peristalsis, you will have pain. So we call it colicky vein. Another form of the analogy. If we have a patient suffering from kidney stones, so the rule says whenever you have an obstruction, okay, whenever you have an obstruction of an organ that peristalses, it will lead to colicky pain that comes and go. Okay, so peristalsis pain, it means that a pain that comes and go. Okay, so if we speak about the yes, of course I can. Look, there is two forms of pains on physical examination. Some patients tell you the pain is persistent, doctor. Well, does it come and go? No. It just keep being there. It's all the time I have the pain. Some patients be like, no. The pain comes and go, you know? So comes and go, this is equal to say colicky vein. Colicky vein, that is a pain that comes and go, okay? So in persistent pain, what's up? Well, it's a problem that is consistently there. We will worry about it later. Forget about it now. But for the colicky vein, it's an obstruction of an hollow organ that contract. Okay? For example, if the gallbladder is here, does the gallbladder contract or not? Can the gallbladder contract? Yes, it does, to secrete the bile. So here is the gallbladder. If the gallbladder has a stone here, and it will contract, during the contraction, it will be pushing the stones. Well, that will be painful. Well, does the gallbladder always contract, or sometimes contracts, sometimes does not contract? On and off or persistent? On and off. So since it is on and off, the pain will be colicky, which means it comes and go. Okay, so this is an organ. Why they have the pain? Because of obstruction of a tube. So if we speak about the appendix and you had a fecalith, the same idea. Obstruction of a tube lead to colicky vein. Okay? One more example is exactly peristalsis induced pain. Another example is the kidney stone. Okay? So kidney stone will lead to the exact same thing. Look what they write. Colicky vein radiating to the groin and hematuria. Guys, you remember when we spoke about the glomerulus and I told you that there is an RBC cast in the urine? Where did we make the RBCs though? Where did we make this RBC cast? The RBC cast were made where exactly? Was it made in the urethra? Exactly, it was made inside of the tubules. It was made inside of the tubules. So the cast was made inside of the tubules. So if you had a kidney stone that is inside of the ureter, not the kidney, the ureter, will you have a cast or not? If it was here. Exactly, you will not have a cast, no cast. Okay, it's blocking a tube. And the ureter itself peristalsis as well. Like it moves, it contracts to try to move the urine inside of it. Is that painful? Yes, it's painful. So since it's painful, it will lead to colicky vein. Yeah? So the next thing you must know about that there will be a backflow of urine backward. That will lead to hydronephrosis, which will destroy your pyramids. Okay? Yeah, not the kidney, the tubules. Remember, if you take a cross section of a ureter histology. Let me show you. Come on. So if you take a look at the histology of the kidney, of ureter, sorry, not the kidney, and you look at its wall, it has a thick muscular layer, okay? So if you notice here, can you see the smooth muscle layer? It's pretty thick, okay? So that contracts, and when it contracts, it will lead to colicky vein, okay? So let me send that to you guys. And the vein and the yes, exactly. Yep. So as you can see, as you saw there, I hope it made sense. Okay, let's add one more point here. So now we speak about this guy. Okay, now they tell us treat and prevent by encouraging fluid intake. Guys, be really careful. If you have a question that tells you about a patient with kidney stones, and long story short, they tell you, oh, what should you give him? Should you alkalinize the urine? Should you, I don't know, do surgery on it? Should you do this sound treatment in which you hit with an ultrasound waves? Should you give thiazide to induce diuresis? Or should you treat him with blah, 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 blah? All of these answers are wrong. The correct answer is hydration. If you overhydrate the patient, the stone will get out. For step 2, I will be teaching you, hopefully, how to treat kidney stones from A to Z. But for now, I want you to know basic concept. I will not go in details because it's not required from you. In general, if the stone is really small, it will go out on its own, okay? But if the stone is really big, you have to do surgery to get it out. So which type of stone is small and which type is big? That's what we are going to see now. So, yes. So calcium stones are the most common types of stone. So we have calcium oxalate, hypocetereteria, and the calcium phosphate, okay? Calcium oxalate, calcium phosphate. So they mention here increased pH. When you have increased pH, is it an acidosis or alkalosis? Alkalosis of the urine, correct. Guys, is calcium white or black on a X-ray? It's white, yes. So we also call it radio-oblique. So on the X-ray, it will be radio-oblique, radio-oblique. On the CT, also radio-oblique. But here is the important thing. When we take the X-ray, actually, sometimes we do an X-ray with contrast, if you know. X-ray, calcium, stone. So we do it with contrast. So when you do it with contrast, you will not be able to see anything. Yeah, here it is. For example, this patient is having a picture of a kidney stone with contrast. Notice. Well, you can see here some contrast inside of the kidney, inside of the tubules. But here there is absence of something, absence of color. Yes, so there is here. Oh yeah, it's radio-oblique, and here there is nothing. Basically, the stone is here, and the stone has prevented the fluid from keeping going. That's why you were able to see it like this. So, yes, the only radiolucent stone is the uric acid. It's the only one. And remember, it has the U in it, uric acid, so it's radiolucent. Okay, so remember when we spoke about like a blood smear, there is a urine smear in which we were able to see the casts on. Except of the cast, you can see other stuff. For example, in case of calcium oxalate stones, you will be able to see what? You will see this. Let me show you. So this is a calcium oxalate stone. This is a gross picture of it. That looks painful. Look how sharp it is. Yep, pretty sharp. And if you take a look at in the urine, you will be able to see the following. cannot find it. Here it is. Yes. Okay, so if you take a look at it, it has this X in the middle. You see a crystal with X in the middle? This is oxalate, okay? So whenever it has an X in the middle, you are thinking about an oxalate type of stone. Okay, so let's just send that. Okay, so it's an oxalate form of a stone. Good. So calcium, radio-oblique, it's shaped like an envelope or dumbbells. So let me explain what this thing about the envelope and the dumbbells. So regarding the envelope, here it is. Not a big of a deal. It looks like an envelope. You know how an envelope, you can open it from here, and this X shape, if you forget, just remember that it's oxalate. So I remember like a friend of mine used to do something like this. It used to be like O and the X is in it, you know, like this is the O, this is the X, and do something like this, oxalate, okay? And I was like, oh, well, this is cool. How are you going to make the dumbbells? And he was like, well, here is a dumbbell. Because, you know, there is a little dumbbell also, you will be able to see it. You're like, what? Dumbbells? Yes, you will be able to see dumbbells. Let me find the dumbbell for you. You know this dumbbell, like weights. Yep, here is the dumbbell. So you will be able also to see a little dumbbell there. That's also in case of calcium oxalate, okay? Let me send you the dumbbell. Okay, so you can see here the dumbbells. I'm sorry for that. Let me just close this. Okay, so you can see the dumbbells there as well. And after the dumbbells, after getting rid of the dumbbells, we have what else we can appreciate in this pathology. They write, calcium stones are the most common form of stones you can have. Calcium oxalate is more common than the calcium phosphate one. So the oxalate, the dumbbells, are the most dominant of them all. Remember when we spoke about a substance called ethanolic glycol? And I told you it's used in this antifreeze for cars. And can someone tell me, please, regarding this ethanolic glycol, which population is at high risk of ingesting it? Who ingest it? Kids and alcoholics. Excellent, good. So it can result from ethanolic glycol, the antifreeze, ingestion, and vitamin C overdose. Oh, you know these people who are like, oh, let's give mega vitamin. It's funny because when I go to the shop, I see it. Some multivitamins, they write on them, take a mega dose of vitamin C. You know that the human need per day is between 500 to 1000 milligram, which is like less than a gram. And you go to the supermarket and read on the can, take 10 times your needed dose from vitamin C, and it's written like 10 grams of vitamin C. But that, the calcium oxalate stone is loving you for that, you know? Okay, so you need per day, I will write you 500 until 1000 milligram per day, nothing more than that. So hypocetereteria as well can be, which is why hypocetereteria. I will speak in the future which condition exactly lead to this, but in general what I want you to know that it's associated with decreased urine pH. So there is a condition that decreases the amount of citrate in your urine, and that alters the pH, and that can precipitate to calcium oxalate stone. And the most important one in this whole kidney stone chapter is the Crohn's disease one. How can a Crohn's disease lead to a kidney stone? You must know that. Look, just a second. Yes, okay. So the kidney stones caused in Crohn's disease, is it a calcium oxalate or it is a calcium phosphate? Okay, so look what happens. Yes, yes, it's like an antistone material. When you don't have it, you will have a higher risk of precipitating a stone because more of this vitamin C will be accumulating in that area, and it will be drawn what will be attaching to it to that area, precipitating into the same area due to the altered pH. It will be the little calcium oxalates, the oxalates. But the most important concept back here is what? What is this structure? This is basically your, okay, let me make a little appendix here. So this is your ilium and this is your cecum, okay? And now I'm going to make a blood vessel. So let's draw a blood vessel here. Okay, good enough. So what happens now? You know, many substances are reabsorbed at this area, including calcium oxalate. Okay, it gets reabsorbed. You're like, okay, good. Calcium oxalate gets reabsorbed here. What else? Fatty acids. Well, cool. Fatty acids gets reabsorbed here. Well, what else? B12. B12 get reabsorbed here. Well, not nice. So, which disease can lead to destruction of your ilium? Which disease destroys your ilium? Well, it's actually Crohn's disease. In case of a Crohn's disease, your ilium is destroyed. It's dysfunctional. It's not working. And when your ilium is destroyed and dysfunctional and not working, what will occur that you will have poor reabsorption of all of these substances, okay? So these substances, when they are not reabsorbed normally, you will have a B12 what? Deficiency. Okay, you have a B12 deficiency. What else will occur except of the B12 deficiency? Will you be able to reabsorb fatty acids? Yes, you will have a serious problem reabsorbing fatty acids normally. You will not be able to basically reabsorb them in the correct way anymore. Okay, so what happens next is actually pretty interesting. This is the most important thing. So the fatty acids, they are not being reabsorbed. So they will bind to what? They will bind to calcium. You are like, okay, nice. So they will bind, the fatty acid will bind to the calcium and they will go outside of the body, correct? Yes, that's what will happen. So let me just move them to the side. Here you have fatty acid together with calcium, yeah? And calcium. And they are going outside, done, goodbye. So what is the problem? This sounds good actually. That will not lead to formation of calcium stone. Well, the thing here is that we have oxalate stone, not calcium stone. So the fatty acids now are binding into your calcium oxalate, and this is going out. They are binding to your calcium, and this is going out. Instead of it, now the oxalate is left behind, yes? Now the oxalate, which normally used to come with calcium, you are not reabsorbing calcium anymore, so you will reabsorb more what? Oxalate, okay? So reabsorbing more oxalate will keep going until it reaches the kidney and lead to oxalate stone. Again, let me explain this pathology because it's really important. Inside of your distal ileum, you have reabsorption of some substances. B12, except of B12, there is other substances, but the important one for you, B12, fatty acids, and oxalate. So it's destroyed. It's not functioning correctly, the walls. So the reabsorption of fatty acids will be bad. What about the reabsorption of basically calcium? It will also be bad. So calcium and fatty acids will go outside of the body together. And actually, when they are inside of the lumen of the colon, they will attach to each other and make one big particle to go outside, okay? So, good. We have fatty acids and calcium outside. What is left? Oxalate. Oxalate will keep going inside of your body and it will be reabsorbed freely into your circulation. So you will have increased amount of oxalate inside of your body. So this oxalate will go to which organ? Kidney, and lead to formation of kidney stones. And if we speak about the oxalated stones, if I look in the urine analysis, what I'm going to see on histology? What do you see in histology? Not histology actually, yeah, you see envelope and a dumble. Yes, I'm asking which type of a crystal do you see in the urine? It's, yeah, envelope and a dumble. Okay, so how do you treat it? Thiazide, citrate, and low sodium diet. Let's explain these. Well, you know, guys, that thiazide is what? It's a diuretic, yeah? Did thiazide lead to hypercalcemia or hypocalcemia? First of all, before even saying that, can somebody tell me where thiazide work, at which tubule? DCT, correct. I will make you remember its function with calcium from the pathology. If you have kidney stone because of more calcium inside of the urine, would you like to put more calcium inside of the urine or less calcium inside of the urine? Less calcium inside of the urine. So thiazide is the treatment for this disease. So is thiazide putting more calcium inside of the urine or less calcium inside of the urine? So basically, thiazide lead to hypocalcemia or hypercalcemia. Well, basically, it's preventing the secretion of the calcium, so there will be more reabsorption of the calcium, which will lead to hypercalcemia, okay? Also, citrate. Can somebody tell me why citrate? And what is citrate, first of all? And in which condition when people consume citrate, basically? Okay. So, okay, I see variable answers, but here's the idea. Citrate is a highly alkaline molecule, okay? And when this highly alkaline molecule accumulate, it will lead, in the urine, it will lead to really increased pH of the urine, which will make it alkaline and it will make the calcium stone appear. So the question comes, where the hell did you get the citrate from? Well, it can be from variable things, but it can be mainly in normal human beings. It can be either from stuff we eat or drink. Also, it can be from destruction of the RBCs. So let's speak about the stuff we eat. There is many juices that contains citrate. Can somebody give me an example of a juice that have a lot of citrate inside of it? Yep. Orange juice. Yeah, citrus fruit basically. Okay, if we speak about calcium phosphate, also there is the low sodium diet. Why? Because low sodium diet decrease the amount of salts going inside of the urine, which eventually decrease the amount of calcium going inside of your urine, which decrease your risk of developing a stone there. And also one more thing, if we speak about the thiazide, it's the gold standard treatment for this disease. If you have two answers that one of them will say treat this disease with thiazide or hydration, what will you choose? Always hydration, okay? So I'm going to send a picture for somebody who asked about how it works exactly. So here you go. Okay, I hope you got it. I don't know. So yeah, basically it works. Yeah, exactly. It works like that. It's a chelator. As you can see this molecule there, it works as a chelator and it binds to the calcium and leading to its precipitation in that area. I hope you know what is a chelator is. Yeah? A chelator is a substance that bind other substances around it and keep them in the place. Okay. So the next thing, it goes something like this. Calcium phosphate, it increases, it's due to increased pH. It's also radio-oblique. The most important thing is to know its shape. It's wedge-shaped prism. So we will take a look at it in a second. Let's take a look at the calcium phosphate stone. It looks actually kind of cool. You mean the hydration or the thiazide you did not get? Okay, I will tell you in a sec. Okay, so let's take a look here. Let's take a look here. First of all, I will explain this concept and come back there. So you can see the prism here, and this prism formation all over the place basically lead to what? A lot of prism. This is calcium phosphate stone, okay? So this prism is the thing that you are going to see in a calcium phosphate stone, okay? So, oops. Okay, so let's speak about that thing that does not make sense. Okay, so let's start with the thiazide. Guys, we said that thiazide reabsorb, I know it looks really cool. Does it lead to reabsorption or excretion of the calcium, the thiazide? Reabsorption. So less calcium or more calcium will be in the urine. Okay, good. Less calcium inside of the urine will lead to more formation of the stone or less formation of a stone? Less formation of a stone. So that's helpful. I mean, this is what we are treating to do. Well, this is what we want to do. Decrease the amount of formation of a stone, you know, because if you have a stone in your kidney, it's a bad thing. Yeah, exactly. So, okay, I think you did not, okay, I think I know what is the problem here. So if we draw a kidney, sorry. If we draw a kidney like this, the stone is happening here. It's not, it could be happening inside of the calyces, but basically it's not happening inside of the tubule. The tubule are inner, you know? So yeah, this calcium will be going back to the circulation, back to your blood. Got it? So if it's going back to your blood, it will not be going inside of your urine. If it's not going inside of your urine, you will not have a stone. Done. Okay, back to this. So let's just speak about, yeah, so you saw the prism, and here's the prism. And the moment you see that, done. You have yourself a diagnosis, okay? That's it. Okay. So most of the time in the USMLE, they will just show you the picture and ask you what caused it or what it is. Okay, so that was the calcium phosphate. Make a note, please. The most common cause of this one is the hyperparathyroidism, okay? So the next thing is ammonium magnesium phosphate, Strovate stone. When you ever hear the word Strovate stone, it's a really big stone. Let me show you how big it is. Okay, so Strovate stone. So this Strovate stone is a massive stone. It's really big by size. I mean, take a look at this. See this whole thing? This whole thing is a stone. This whole thing was inside of someone's kidney. Yep, look, it looks like ginger. And is it painful, guys? Do you think it's painful? Yeah, it's really painful. And it's basically can lead to colicky vein, okay? So, and well, would thiazide work for something like this? No way, it's too big for thiazide. So we will not exactly, you must do surgery. So about what surgery to do about it, there's many surgeries you can consider, you know. There is something called the shock wave, okay? You can try it. Sadly, it does not work that often. You can try it for like not so big, not so small stone, average size stone, you know. But really big stone, like the one I just showed you, even that will not work. But basically, what is the shock wave? In smaller, the Staghorn stone is the big one I showed you. But let's imagine, because I forgot to tell you about this treatment, in a calcium stone, which is like smaller than this one. In a calcium stone, it's much smaller. So you can focus this shock wave treatment on it, in which like little waves will be pushing against the ureter until they will crush that stone and it will clear out. Okay? It's quite cool. Yep. Something like this. Shock wave becomes smaller and you get it out. Okay. So the next thing here you can see the ammonium magnesium phosphate Strovate stone. Well, again, the pH is high. And I will teach you a trick actually about this one to be really comfortable dealing with them. But let's finish them one time and then I will give you the tricks. So the bilucency, all of these stones are radio-oblique except the uric acid one. So what you are going to see, the coffin lead. Well, this is the coffin lead. Look how it looks like. Okay. So the coffin lead. So the idea of the coffin lead that you take a look at it at the crystal, and the crystal look like a coffin lead, as you can see. Yeah. So this is the coffin lead stone. The moment you see it, you think about what? You think about a Strovate stone, as you can see here. Okay. Oh, actually, wait a second. Okay. So here you go. So let me try this actually. I just noticed, yeah, what is this one? What is this? It's a prism, correct. So it's a calcium phosphate stone. Excellent. Good. What about this one? Oxalate. This is a calcium oxalate. Why? It looks like an envelope. Okay, good. So, okay, let's keep going. There is something here, ammonium magnesium phosphate. Personally, I always told myself it's MAP, magnesium phosphate ammonium. Okay? Magnesium phosphate ammonium, it's a MAP. It makes me remember the names much more easily. So why it happens? It's because of bacteria that start releasing this ammonia and magnesium and phosphate. So the bacteria will be releasing these substances. When the bacteria releases these substances, you will have slowly increase in the pH. And that increase in the pH will lead to alkalinization of the urine, which will precipitate formation of the stone, which is made from the ammonia, which comes from the bacteria, the magnesium and phosphate, which also comes from the bacteria. So they write it accounts for 15% of the stone. It's caused by an infection with any organism that is urease positive. Why urease positive? All organisms that are urease positive convert urea into ammonia, yes? And what we said the name of the, like the stone, it was the MAP, yeah? Magnesium, ammonium. So you see, you must have urease to make ammonia. And ammonia is alkaline or acidic? Someone write me. Okay, so let me try this. Am I still breaking? Can you hear me normally? Can you hear me? Okay, good. Somebody just joined. Okay, so let's go back here. If we speak about urease positive organisms, they basically convert the urea into ammonia, and that ammonia is alkaline. That alkaline makes basically the pH much higher. When the pH is much higher, that will lead to a precipitation of the stone. So which bugs are urease positive that can lead to formation of ammonia, which can lead to formation of the stone? Well, this includes the Proteus mirabilis. There is something really important you need to know about the Proteus mirabilis for the USMLE. It's about its movement. It has something called tumbling motility, okay? So you need to take a look at tumbling motility and just like spot it, know it, and be comfortable with it. So just a second. So on what it looks like is something like this. Take a look, guys. See how it moves? See it? Pretty cool, huh? So that's the tumbling motility. Okay. Am I still breaking on you guys? Can somebody tell me if you can hear me? Can you hear me normally or not? Okay, if it happens again, we will take a break. Okay, so basically you saw what is tumbling motility, which is also called swarming motility, which is basically a form of movement that happens of the bacteria. Okay, look how beautiful. Oh yeah, see, pretty cool. It can move. So that's a Proteus mirabilis. And if we go back to this one, we have Staphylococcus aureus, Staphylococcus saprophyticus, and there is few things that you must know about actually, guys. The Staphylococcus saprophyticus, first of all, make a note, it's in sexually active ladies, young ladies, and it's the second most common cause of urinary tract infection in sexually active ladies of a young age, okay? So it's a Staphylococcus saprophyticus. Keep in mind that the treatment of this bug is with vancomycin, a big, like really strong one. Yes, it's super enough for this. It's super enough. Like it mentioned everything about it. You just need to know that about the novobiocin resistance and that it's urease positive. And that's it. That's everything you need to know. You need to know it's coagulase negative, which all of this is mentioned in Sketchy, which actually, guys, I wanted to speak with you about. Pretty soon we will be starting microbiology, I think, after biochemistry, and I would like you to start Sketchy. So anybody who does not have a Sketchy, please contact me. I will give you a version of Sketchy. And for all of you, you must know one thing. By the end of next month, you will be doing one self-assessment, okay? So you will be, at the end of next month, you will do your first self-assessment for those who did not do it already. And most of you, even if you get a bad score, do not get demoralized because all of us failed our first self-assessment, okay? Then that will be your first line, and from there, we will need to build you up until you pass your exam. So keep in mind at the end of this year, basically, you will be doing your first self-assessment. Okay, let's take a look. So Klebsiella can lead to it. There is something important about the Klebsiella. It's one of these encapsulated organisms. Guys, do you know what is Serratia? Serratia. There is something called Serratia. Yep. Serratia also can lead to to a problem like this. If you don't clean your bathroom for a really long time, it becomes pinkish. And then really nasty bathrooms, you can find, oh, this is disgusting. Well, you can see something like this, okay? When you see this thing, this is basically Serratia going around. Oh yeah, a drug resistance bacteria in your bathroom. I know, it's amazing. So, it's just forming a culture in your bathroom. So let's go back to this one. So they write, this organism hydrolyzes urea to ammonia because they are urease positive, and that leads to urine alkalinization, and commonly form a Staghorn Calculi, which is really big. Look at how big this one is. And they also write that treatment is with eradication of the underlying infection, which we spoke about. It is according to the organism. And the biggest stone will not go out with a drug. You must take it out surgically. And yeah, that's it for these two types of stone. And now we'll take a break, one more session, and then we call it off for today.